Okay, are we ready? I think we are.
Are we good? Getting close?
So, okay. So good afternoon. Thank you for being here. My name is Dr. Kristen McAlexander. I'm the Department Chair of Exercise Science and Sport Management. We appreciate your time. We appreciate those that are live streaming right now. And I have the pleasure of introducing our Department Operations Coordinator, Dylan Constantino. Dylan will be doing our introduction of our Peterson Health staff.
Thank you, Dr. Matt. Thank you, Dr. Matt. Thank you. So I apologize. I know I went over them before, but I apologize again if I butcher some names. But we have Samantha Aminosa. Imisano, sorry, who's a physical therapist. We have Catherine Kambusta. There we go. Who's an occupational therapist. We have Candace Ibatson, who's a speech therapist. We have Mary Bartlett, who's a nurse, and then we have Colby Madron, who is a rehab tech. So again, thank you guys for coming and for your time and everything.
Ready? Yep. Is there any particular place I'm supposed to stand or right here? Because they're gonna want sure. Yes. So stand about right here? Yes, ma'am. Ooh. Am I looking? Oh, so this is the camera right there? Mm-hmm. All right. Colby. My name is Candace Ibbotson, and I'm a speech pathologist. And how do may I advance it? Do you mind? No. I'm kind of bossy, you know that. I'm sorry. Which way do I go? This way or sorry? I'm Texas Aggie, class of 77. Mask. We have to do the mask. Okay, I'll go back. I may have to take it off to breathe. Anyway, I'm Candace Ibbotson, and I'm a speech pathologist. I've been a speech path about 38 years, 28 years in the hospital setting. It's truly an honor to be able to be here and represent Peterson Health. I think the greatest highlight of what we do in our career is to be able to pass on our knowledge, our experience, our passion, our purpose, the reasons why we do what we do and why we became what we did. And so to be able to have this time to pass it on to you guys is the highest honor. So many people have come into my life, worked with me to make me who I am. And they took time out that they really didn't need to take. And they saw excellence and they built on excellence. And so it's really just a great honor for all of us to be here. We have like the best rehab team in the whole world. We rock. And in the end of my career, I would have to say this is the best rehab team I've ever worked with and absolutely the best hospital system I've ever worked in. So Peterson Health is the best. We have about 124 private rooms. All of our rooms are private. We have many departments, emergency room department. We have an observation unit where people come in from the emergency room, maybe are a little bit sicker than they should be. They come into our hospital and then decisions are made. Do they get admitted to the hospital or do they go home and receive other services like rehab? We have an inpatient rehab unit on the third floor, and these patients are sick, have had significant medical illnesses, come into our inpatient rehab unit for therapy to return home or to work. They need to be able to tolerate about 3 hours a day. And they need to be really motivated and have a desire to achieve that. And of course, our nurses and our rehab team is a big focus of our efforts in the hospital system, our inpatient rehab unit. And of course, we have general surgery and we give births to babies and all sorts of wonderful things. We have an outpatient center called the Ambulatory Care Center, and it's called ACC, does amazing things. Labs, x-ray, wound care, rehab. So it allows people in our community to come into this setting and get the medical care that they need in the most efficient and orderly manner. And of course, Medicare, private insurance, different programs help to pay for these medical fees, but it's a great asset for our community, for people like you. I hope that one day y'all can come and visit and see it. It's very amazing. It's orderly and it's beautiful. It's a beautiful center. It brings a lot of healing to our patients. So our acute rehab unit, we have 28 private rooms. We have what we call a transitional apartment. We hope that you can come and see it. We would love to have you. We have this apartment that at the end of their time, based on their function, can they walk? Are they safe in being by themselves? Maybe they have a family member that can stay with them, hopefully status post-COVID. And it's a 2-bedroom apartment, and they can cook in it and wash clothes in it and all those things, a normal bed to sleep on, and it allows them to transition into a regular place. We have this wonderful walking path that Dr. Foster, our medical rehab director, created and designed, and it's made up different surfaces and mailbox and bridges and all sorts of things. I broke my foot 4 years ago. I practiced on it. It's really a great way to get our patients outside and to be able to feel outside, feel the air, and then do the kind of therapy that they need to do with PT and OT. They don't let me out there too often, but I do sneak out there on occasion. We have a raised garden where we can grow things, they can stand up. So the PTs, OTs, and all, we try to make what we do functional. We want people to enjoy doing it. They may not realize they're standing for 20 minutes, but then that allows them to return home and wash clothes or whatever. So it's pretty cool. A private dining area and a gym. I go this way. 3 disciplines: PT, physical therapy, occupational therapy, and speech therapy are our 3 disciplines. These 3 disciplines are in the hospital setting, our inpatient rehab setting, also in our outpatient setting. And we work together. Never, and I've been a leader for 25 years. I've never had a rehab team ever work closer together. We may not always agree. We may disagree. We have strong opinions, but ultimately we come together, agree, disagree a little bit, but the biggest thing is the focus on the patient. Where are we trying to take that patient and outcomes? And it is a magical thing. I run to work because of these rehab people and of course nursing. We cannot forget nursing. We talked about 3 hours of therapy. The patients basically get 6 days of therapy in our inpatient rehab unit. Now, of course, in the acute setting, we often will go and do evals and treats, and we may not see them but every once in a while until they're discharged, but we do follow a plan of care for that. We work from 8 to 5, and some people like me work later than 8 to 5, but we do have a full day. It's a busy day, and we sometimes have to work on weekends. We care for, in the hospital and in our inpatient rehab setting, predominantly strokes, people with traumatic brain injuries, spinal cord injuries, amputations, cardiac, orthopedic, and illnesses that just cause great illness. Someone who's been critically ill, has been in the hospital 5 weeks for various reasons like respiratory failure, and then all of a sudden they maybe develop a wound or they develop a pneumonia, and so they're in the hospital quite a while. And so these are the patients that we really receive into our unit. Right now we have quite a few of them. We bring them from barely lifting their heads off the pillow to being able to walk and sometimes walk out of the hospital, and it is amazing. It's all a process, and so we build on that process. Speech language pathology, my favorite. I love what I do. How could anyone have the greater honor to be able to teach someone to talk again? I would give up nearly everything but my ability to eat. How many people would give up eating? Anybody? How many of you guys behind this silly screen would give up being able to communicate? It is what we are in our identity. It is our ego. It is our passion. It's what defines us. It's our history. And we want to be able to speak and we want to be able to communicate. So speech pathologists, we do a lot. Our biggest focus probably in the hospital setting as a speech path, and it's something I learned in my career. I didn't learn it initially in graduate school, was how to do swallowing therapy. So we assess people and we figure out how they can eat, what best foods to eat, what are techniques to help them eat better. We take people from not being able to eat at all, nothing, with peg feedings, and we take them where most of them by the time they leave are on a regular diet or a slightly monitored diet. We work on increasing their intake and reducing their risk of any food going into their lungs. All of this stuff is taken for granted. Nobody thinks of swallowing. Nobody thinks of the muscles or the nerves or the effort or the energy or the attention to eat and swallow. It requires a lot. So we form a plan. I spend a lot of time in the lunchroom with my patients, and we get them to where they're functional. If they're not, we do other things, but we're generally very successful. One of the biggest goals is we don't want them to get pneumonia. You can really die from aspirational pneumonia. And also, if they return to the hospital with pneumonia, it sometimes affects insurance reimbursement and these kinds of things. Let me go back a little bit. So in speech therapy, we work in the school systems, and we work in the hospitals, we work in home health, we work in outpatient clinics, we work with MR, people that have severe learning disabilities, we work with pediatrics, we work with newborn children up. So in the continuum of care, we go from pretty much birth to death, geriatrics. I have pretty much done all of it from birth to geriatrics. Really, every approach I do with the elderly is really the same approach we do with children. We want to get there, we want to identify them, we want to establish trust, we want to see what do they want to do, what is impacting them, what is their biggest desire to return to work, what can I do to get you back to work? So all of that involves the listening component, processing, making associations, reading, writing, and then cognition. So one of the things, again, that we take for granted is this cognition thing. I get into trouble about this. Sometimes I get called into the principal's office or my director's office. Mrs. Smith is not happy that you worked with Mr. Smith on his thinking. There is nothing wrong with how he thinks. So somehow, as a speech path, and PT and OT really helped me on this, we appeal to them. We're working on his attention. We're working on his problem solving. We're working on sequencing. PT is working on these steps. So I, in speech therapy, can help you guys learn those steps. The rehab tech can come to me and say, hey, this is going on with the husband and the wife. They're really needing help on maybe how to manage their finances, or maybe they need supervision with their medication management. I can teach them techniques to improve their cognition and their thinking at home. Pillars of language, reading, writing, talking, understanding. The umbrella is problem solving, safety awareness, short-term memory, immediate memory, and all of those things. I did not look at the time when I started. Am I okay? Are you sure? Y'all hit me or something if I go over.
All right.
I've been accused of being a little bit too talkative through this.
Doing great.
Am I doing great? As long as I get a thumbs up from you guys. Kat, am I okay?
You're okay.
Am I behaving? Okay. We have fun. When you stop having fun, you really should start doing something else. I want to go into this, but Sam asked me to tell a story. And I talked to some of you guys. Y'all are just precious young people. I will pray that every one of you achieve your goals and know that people like us are rooting for you, because you're going to continue what we're doing right now. So Sam said I was supposed to talk about what caused me to become a speech pathologist. Well, I was at Texas A&M University, class of 1977. Y'all can do the math later. I was a pre-med biology major. And I married my senior year. May or may not have been the best idea. It certainly kept me from becoming a doctor. We went to Germany. And my husband was a field artillery officer. And he was, I was just so excited. I'm in Germany. And then all of a sudden he disappears. I didn't see him for months. I've never left home. My mama would call me and all I would do was cry. And mom would say, Candace, this is costing me so much money to hear you cry. So I decided I was going to do something. I was going to join the Red Cross. So I'd fill out this application at the biggest military hospital in Germany, in Nuremberg. And I signed up and I filled out, I went to A&M and I have a bachelor's degree in biology and all this stuff. And they assigned me to the speech therapy department. Never had heard of speech therapy. I'm a little country bumpkin. So this poor little speech pathologist, who now I think is probably sainted, was a hospital therapist, was the pediatric therapist. She was the home health therapist, and she was probably every other kind of area of the speech therapist. So she said, Candace, will you help me? So every day for 2 years, I went and I made all sorts of things. I probably did therapy, Colby, that I shouldn't have done, but we made it work. So my husband was allowed to go back to graduate school And she said to me, Candace, have you ever thought, do you think you're going to go back to doctor school? And I said, no, ma'am, I just don't see how I'm going to do it. She said, why don't you apply at speech pathology, be a speech therapist? You would be great. You're so good at it. So anyway, my husband was accepted at Baylor, and I was accepted at Baylor. I was the first non-Baylor graduate into the speech program, and I got called into the dean's office, and he said, I'm not going to let you start. So my mom always taught me when something's really bad, this guy was like 150 years old, I was going to stand up really straight, probably as old as I am right now, real straight. And I said to him, I'm just come from Germany and I am going to go into the graduate program, sir. I really appreciate it. Put me on probation. We ended up being the top graduate. So don't be discouraged. Different things will happen in your career. Why is this happening? Why I'm not getting what I want? I don't like how that person responded to my desire, but it all works out in the long run. So let me go back so to become a speech pathologist, you have a bachelor's degree. You can get it in speech pathology as an undergraduate. They nearly prefer now that you have another degree process. It has become so medically complex. They would love you to have a biology or some sort of science degree. You have to make really good grades, really good grades. I've taught at 2 or 3 universities. You need to be the top student, and you have to go into it as the top student. You work and you get your master's degree. And then we also have a doctoral program. But the problem right now with our doctoral program is our speech pathologists now go to 4 years of college. They have to go to 2 years of a master's program, and they have a 1-year fellowship. So it's about 7 years. It passes really fast. It's not that big of a deal. I think ultimately we're developing more doctoral programs, but right now our master's program is nearly equating some doctoral programs. And so ASHA, the American Speech and Hearing Association, is working on that. Most of our speech pathologists will end up getting a PhD, and it's a little bit higher level of education. But as far as most speech paths working in the community, working in hospitals, they have a master's degree. And then when they finish their CFY, they have what we call a certificate of clinical competence, which is an extra level of certification to allow their competencies. So I think on that note, is this my last slide? I think so. I don't like fate. I think it's all a process. And if y'all ever have any questions, please, please, please email me, ask to come see me. I have a lot of students and I would love to do it. And I'm gonna pass you on to.
They're ready. Sorry.
Oh, I'm
They're
sorry.
You're okay.
And I'll pass you on to Kat.
Ready?
Yeah.
All right. So I'm Kat Bitsta. I'm an occupational therapist. A lot of people don't know what we are and what we do. A lot of people see us and they think that we're physical therapists. And while I love my physical therapists, we are very different. So we focus on things that are called activities of daily living and instrumental activities of daily living. So in the hospital setting, with the population that we have here, we do a lot of showers. We help people learn how to dress themselves again after a stroke. You can imagine they can't utilize half their body. That's going to change drastically how they're going to get themselves dressed. It's also going to change how they're able to go use the restroom. So we focus a lot on these activities of daily living, the things that are essential to make it so that you feel like you are a person. And then we also focus on IADLs, or instrumental activities of daily living. Those are all the things that you love to do, and we want to help you get back there. So if you are a sports player, we want to help you identify ways that you can get back to playing sports. Along with working at Peterson, I also work for an organization called Kinetic Kids. It's an organization that helps to bring sports to kids that have disabilities. So I'm actively working with my volunteers and their parents and the kiddos to come up with ways to adapt whatever sport we're doing so that they can actually participate in it, which is awesome. We also kind of address mobility, but really it's just when we're addressing how do we get on and off the toilet. PT focuses on everything else. If you ask me how to help somebody go up the stairs, oh, look at you like you are crazy. So we look at it very differently than the physical therapists do. We also assist with finding adaptive equipment. So I'm going to talk about strokes because we have a lot of those, but you can't utilize one of your hands, but you can use your elbow. We can get a universal cuff to put it around your hand so that you can still self-feed, because that universal cuff, you can put your utensils and things in. So If we're doing something like that, we actively work with our speech therapist to make sure that they can be eating what we're asking them to eat. Is the utensil that we're asking them to use, is it appropriate? Things like that. When I worked in the schools, we actually had a guy come and help mold a wheelchair to one of our kiddos' bodies. She had CP and she needed a very custom wheelchair. So he came, did this whole molding process. It was awesome. So we do assist with those things as well. Like Candace talked about, we are able to see individuals from newborns all the way up through the hospice care, which is where individuals are going at end of life. So we do have individuals in all areas, along with schools, inpatient, outpatient, home health. I mean, all of those different settings. So we work in the same ones. We also get to supervise CODAs. Colby is becoming one of these. The difference between like a CODA and an occupational therapist, I get to do a whole lot of assessments and write goals. And then Colby will come in and she'll actually take over the plan of care and she'll assist the patients thereafter. We can both treat patients, but she's not going to be doing any of our assessments. So it's a little bit different, but still such a vital part to our team. And they do have to be supervised by an OT. So she would be coming to me. I'd sign off on her notes. We'd sign off if we have to change goals. She sees something that a patient needs to work on a little bit more. We talk about it, determine if it's an actual goal. So our CODAs are really, really important for us.
Less paperwork too that I have to do.
Yes, it is a lot less paperwork for them. I tried to get her to go be an OT, but
They
One day.
They do have bridge programs. That
they
you can do later on if you so choose.
So that's kind of our overview of just like what OT is in general. I'll come back to that. But my journey, so I actually did not have any sort of medical background other than I grew up in a hospital because that's where my entire family worked. I went to the University of Arizona for an undergraduate degree and my first master's. I actually have it in agricultural education and I taught high school for 8 years. I had no idea that what I was teaching was actually occupational therapy. I would have an equine class and we would be talking about adaptive saddles and how did the kids, like if we had an amputee, how would we adapt that saddle to help that not patient, but that individual at that time. So I had no idea I was already doing that. When I left teaching, I honestly thought that I was going to go to PT school. When I turned in my resignation letter, it said, I'm going back to PT school. And then I shadowed one and it was not for me. It's just a very different wavelength of thinking. And I am not that wavelength of thinking. But I saw an OT actually working with a young girl. She had a stroke. She actually fell off of her horse while she had her stroke. And I just felt head over heels in love with what they were doing with her to help her get back to actually doing that IADL of horseback riding. So I started retaking my prereqs because I graduated from college more than 10 years ago. And your classes have to be within a 10-year window. So I had to retake classes that I was actually teaching at the community college level. It was very strange. But as I was retaking my prereqs, I applied for school and I didn't get in. It happens. It does. The number of individuals that get in or that apply is like 800 people. And like my program had 32 slots. So while Candace was talking about it is difficult, you do need to be top of your class. What I loved about OT too is that they looked at you as a holistic person. So it wasn't necessarily all about grades. You had to have the grades. You had to do well on your ACTs and all that stuff. Not ACTs. Not SATs. GREs, thank you. But they looked at your community service hours. They looked at where had you worked. They looked at all of these other things that make you who you are. So just keep that in mind as you guys are going through school, that you do want to build up that side of your academics as well. I then applied to 4 schools the second round. I got into all 4 of them. One of them was my dream school in Arizona, and I turned them down to come here to Texas. I entered school again when I was 33 years old. My priorities in life had changed. I had been away from my family for almost 10 years because being an ag teacher, you work 360 days a year. So I made the active decision to move to Texas because my family had moved here so I could be closer to them. So as you guys are going, you also need to make some of those tough decisions. You might get into a school that you think this is where I want to go, this is what I want, and then taking a look. Is that school that's maybe I don't know, $80,000 more for the same degree. Is that really what you want to spend your money on at that point? So just evaluate what you want, because I could still become an OT whether I went to NAU or if I came here to UTESCA. So I graduated almost 2 years ago now, and I'm actually doing my doctorate degree at Baylor. So that's kind of my journey of how I got here. It's kind of a roundabout journey. There's more definitely like straight shooting. A lot of my classmates went straight from their undergraduate to our master's level program, which is now a doctorate level program. So you don't have to do what I did, you know. But how you become an OT is you do have to have a 4-year undergraduate degree. A lot of my classmates were in education, some kinesiology, some just science in general. Find an accredited school, so that's through this program. All of our programs are moving towards the doctorate level. There are still some master's programs out there, but unlike with me where I went undergraduate, master's, doctorate, it's going to be undergraduate doctorate. So it's an entry-level doctorate. And it basically makes you the same level or entry-level practitioner as a master's levels class, but they are adding a little bit more research base into our programs because we want to be what's called evidence-based therapy. So we want to take what researchers are doing, and if they have assessments or if they have interventions that they have found work really well, and we want to be able to implement those. So the doctorate level really teaches you how to take those studies and actually implement them into the practice. So in the future, all of our programs will be doctorate levels. And this also includes any sort of internships, school-based work, a thesis or doctorate level project. Right now, I'm looking at, you guys know who Medicare is, and I'm looking at my doctorate level program thesis being on something dealing with our new billing system that we have. So it just depends on what you're interested in. And then you do have to pass your national boards and any state exams that you have. But I will say the things that I've gotten to do since coming to Texas and becoming an OT, I've been here for 4 years and I've gotten to travel a lot. So when I was in school, I went to Big Bend with my classmates. I went to Coventry, which is in England, and the school paid for the trip 100%. So what we did is we went over and we took a look to see how their medical system is very different than ours and what could we learn from them. So we were able to gather all that information and bring it back to our school and give them some information. The bottom picture is actually like 2 days ago. I was in Montana. Bottom left. Yep. Okay, that one. The middle one is obviously me holding up both of my hoods for my master's degrees. I think it's kind of cool that I have two. I don't know. The top picture, that's actually the rehab staff. I did my internship at Peterson and then was lucky enough to get hired. And I think that says a lot about, it says a lot about a hospital and a town and a city if the students want to return to them, because it means that they had a really good experience there. And not to say that my other experiences at all my other clinics and my school districts weren't great, but Peterson, I really did fall in love with them. And it's funny because I've taught since I was 16. So I always thought that I would work with kids. There was never any doubt in my head. And then I came to Peterson and I love the geriatric population. I do. Dementia patients are by far my most favorite. And I'm actually dementia care certified so that I can work heavily with that population. So there's lots of little certifications you can get. I also work for Kinetic Kids. That's a picture of us in the pool. I'm one of their swim directors. And then the two little people, those are not my children. That's my niece and my nephew. So I've actually got to see them grow up as I've stayed here in Texas, which has been really, really important for me. So just, again, it's kind of evaluate what's the most important for you guys as you're taking your next steps and choose with your heart. It's not always going to be what your brain tells you is what's supposed to be happening. So. And that's me right there. So y'all have any questions? Sam is going to come up and chat about physical therapy.
Let's find an exit. Give me 1 minute. Y'all get it?
Everybody still ready? Cool. Okay. So I'm Sam. I am a physical therapist. So far you've heard quite a bit about each of the disciplines. And like Candace was saying, we all work very heavily together. So the way I like to think about it is we're getting people back to doing their life. What do they like to do? what were they doing before, and how are we able to help them the best? Like Candace was saying, we all work so strongly together, and there's a lot of overlap too. So there's a lot of things that we support each other with, and it's having such a good team is really, really amazing that we're able to provide the best patient care that we possibly can. So as a physical therapist, we like to call ourselves movement experts. So we teach walking, we teach getting up from a chair, something you probably don't even think about. You just hop up from a chair with not even a second thought. Going up the stairs, getting in and out of your car. I bet you don't think about that very often, unless maybe you're carrying something heavy. In that case, Kat will come in and she would teach you how to do that. And any other kind of exercise, like really gross general movements that you would do on a normal day-to-day basis. So we try to figure out what the problems are. Is it pain? Is it a lack of innervation? So maybe if someone had a stroke, their brain just isn't functioning, those messages aren't getting through. We teach people how to compensate and how to restore that function that they had before. We prevent future disability. Maybe someone has Parkinson's, something that's not going to go away, unfortunately, but we can try to teach them to be the most mobile that they can be and the most independent as possible. Because who wants to rely on someone for the rest of their life, right? You want to try to do the most you can for yourself. We give lots of exercises, of course. We send people with homework. We help people with balance, especially in a community like Kerrville, where we have a lot of geriatric and elderly patients. As you get older, your balance tends to get worse. It just will happen to all of us. So unfortunately, there's a lot of falls in this area, but that is a really, really major part of what physical therapists do, is teach people how to balance a little bit better and stay as stable as possible. And then, of course, trying to get them stronger, trying to get their endurance better. Some of the patients we work with, when Candace was telling y'all a little bit about who we see, is people who've been sick for a while. And obviously that's been happening more and more frequently with COVID, but it can happen from anything. Maybe the person had just had pneumonia. Maybe they had a major heart surgery and it just knocked them for a loop and they just cannot stand up. They're winded walking to the bathroom. We start to build a little bit to get them to be able to walk to the bathroom again, to walk down the block again. You know, those things take time. Think about when you haven't exercised for a while, or you're starting a new sport, or you're starting a new season, how out of shape you feel. Imagine that, but on a much, much lower level. So it's really a key thing that we're able to do. So how do you get to this point? Lots and lots of school. So if you like school, this is for you. It can be 6 to 7 years total, and there's a couple different routes. So pretty much in all of the United States, I want to say, I think every program now is a doctorate level program. It used to be, I want to say 4 or 5 years ago, that there were some that were master's programs and some that were doctorate programs. The reason for that, the move towards a doctorate level program, is the addition of classes for diagnosis. So we're not a medical doctor, so I can't tell Colby that she has diabetes, not quite. But I can say, okay, well, Colby, I really think you might have a sprained ankle, or, you definitely have some balance issues. That's for sure, like those kinds of things. But I do need to know what diabetes looks like. I need to know what heart failure looks like. I need to know if someone possibly might have cancer. So you have to take other classes to know what those things look like. But you can't diagnose this. What you do is refer out to a doctor. But in your head, you might know that that's what's going on. The reason being is that there's also a push in all of the United States to have what we call direct access. So instead of going to the doctor and saying, okay, well, I think I sprained my ankle, and I'm going, okay, well, let me write you a script and you go to physical therapy now. They're cutting out the doctor. And if you think you sprained your ankle, you think you hurt your elbow, you think something's going on, maybe you have a concussion, you can go straight to a physical therapist and they can screen you and figure out, is this something I can work on? Or is this something that we need to send to an actual medical doctor? So that's the push for having those extra classes. You also learn how to read x-rays, MRIs, CTs, those kinds of things that patients might bring with them. So all those extra things are super important. The 2 routes that you could go to get to PT school are it's called a 3+ program. So let's say that Schreiner had a PT program and you knew going in that you wanted to be a physical therapist. So probably around your sophomore year, junior year, you'd say, okay, well, I really think I want to do PT, and you might have to maintain a 3.2 GPA, something like that. But during your senior year, instead of continuing choosing your classes, that would be your first year of physical therapy school. So technically your senior year would be your junior year and you would start. And so it cuts out a little bit of time. There are programs like that, but the other route you can go is finish your full undergraduate degree and then apply and go to physical therapy school following that, which is what I did, and I call it the long route, but it's okay. I called it the scenic route too, so that's all right. And then after you finish your physical therapy degree, you'll take a big board exam. Basically, everything you've ever learned in all of physical therapy and some of undergrad, all in one test. It's very, very fun. So we talked about the length of undergraduate and graduate. 80% of your time is spent in classroom and lab. So is anyone taking like a chem or a bio lab at all? A little bit? Okay. So you go and you do your lab, you write it up, and you leave. When I say lab for physical therapy, be prepared to lift people. Be prepared to check muscle strength. Be prepared to measure heart rate, blood pressure, all those things. Be prepared to touch people, for sure. So when you start school, and I think probably occupational therapy school as well, and definitely speech therapy, I'm sure you have to touch someone's mouth at some point during there. Yeah. You become very, very close with your classmates because you are touching everybody. And because this is a field where you're very close to people and you will learn a skill that you didn't really think about before of being close to someone and making them feel comfortable with you while also respecting boundaries. So that's something you learn kind of right out of the gate. The other 20% of the time, you will be out in the field, we call it. So going to do your internships, your clinical education. So when a physician, a medical doctor graduates med school, they go out and they do their residency, right? So they go to a hospital and they're not a full doc, they have their doctorate degree, but they're still kind of working towards things. They're still learning. It's very similar in this aspect. Each program is different. Sometimes you'll start your clinical rotations a little bit earlier on, maybe your second or third year, and some of them you save them all until the end. Mine was a little bit split up. So I learned about orthopedics, knees and ankles and hips and elbows, oh my, and then I went and did my orthopedic rotation. And then I had 3 at the very end that were very different locations. Typically they try to get you a little bit of each setting if they can, depending on the program. Some programs you have to do orthopedics, you have to go to a school and do pediatrics, you have to go to a hospital. But some programs give you a little leeway and they'll say, well, what do you like? What do you think you're interested in? So during your first or second year, you kind of start thinking, well, what do I like? And that way, when you go into the job market, you're not leaving a job every 6 months because I don't know if pediatrics is for me. I don't know if I want to work with geriatrics. So that's a really nice thing about it. The other good thing about having a doctorate level degree is it's different from a physician in that you learn everything during your first round during physical therapy school. So I work in a hospital and I work with the patient population that we spoke about. But tomorrow, if I woke up and I went, you know what? I don't really think I like stroke patients anymore. I think I want to go to a school and I want to do pediatrics. I can do that. But you're certified in everything, which is awesome. You can go get further schooling as you can in anything in life, but you can switch whenever you want, which is really, really nice. It opens up a lot of things and gives you a lot of different avenues to go down. So some of the classes that you'll be taking in preparation for school, biology and anatomy, obviously, that's a given, right? Cellular histology, I don't think I had something, I think mine was called biology or something similar. Physiology and exercise physiology, so basically how your body processes oxygen and glucose and sugar and those kinds of things when you're exercising, or how your body responds to exercise when you're in the mountains of Montana or in water or humidity. Biomechanics, which is basically physics. Has anyone taken physics? Okay. Teeter-totters and vectors, but in your elbow. A little more manageable. I was not a physics person. Kinesiology, which translates to movement science. That's the big one. That is really what physical therapy is. Neuroscience, pharmacology, which is medicine, pathology, how does disease work? How does your body respond to disease? Behavioral sciences, communication, ethics and values, something we wouldn't really think about right away, but so important because we are a people career. Every single person here is in the people career, and you will run across some things that your values and ethics will be challenged. Management science, finance, sociology, clinical reasoning, okay, your ability to decide the best thing for your patient in that moment. Evidence-based, so what does the research say about what we're doing, because things change all the time. Cardiovascular and pulmonary, endocrine and metabolic, and then musculoskeletal. That is our bread and butter. Your nerves, your muscles, your bones. You have to know all about that. Okay, so I usually recommend, and most schools recommend, you start thinking about your prerequisites 2 years before, only because it makes your life a little bit easier down the line. You don't want to apply to a school and go, oh man, I'm missing Chem 2, something like that. And that doesn't mean that if you decide your last semester in college that you really want to be a PT, of course it's absolutely possible, okay? Seek help from your advisor ahead of time if you can, just so that you can expedite that, just how I was explaining before. Look at your course prerequisites. You want to get PT observation hours. So start looking now if you're able to shadow someone. I know things have been a little tricky with COVID, but I think we're slowly coming back around here and opening things back up. So try to get some hours to see if what you'll need for your application, but it also helps you to know what interests you and is this the right thing for you. It really saved Kat. She was wanting to be a PT and went, oh man, this is not for me. So it actually is very helpful, and I think that's a big reason why they ask you to do observation hours. And if you can, try to do it in a couple different places. It's great to do an outpatient physical therapy clinic or 1 or 2, but if you can, go to a school, go to a hospital. See if there's, because maybe you don't really don't like hospitals, but you really like kids and you want to work in a school. So something to consider. Take the GRE, which is the SAT for graduate school, basically. Request references, so keep good contact with professors if you did a really good job and you had a strong relationship with them, and they know a lot about you. Keep in touch with them, and apply early, because some programs do what we call a rolling admission. So as you turn in your application, they'll look at it and go yay or nay. Oh, I'm added to the stack. So sometimes that's good and it can work in your favor, and other times if you apply late and it's rolling and they only have 32 slots and they've filled 29 of them, you're competing with whoever else is applying at that same time. Okay, so how did I get here? So I was here in November talking to a few, I don't recognize anyone's faces, but I was here in November talking about my journey to be a physical therapist. And I was telling them about my schooling and how I went to Penn State, which is in Pennsylvania, and then I went to Seton Hall, which is in New Jersey, and took my board exam, and then now I'm working in Kerrville. Might have gotten a little lost somewhere along the way there. I knew about halfway through PT school that I really wanted to work with stroke patients. And an acute rehab setting like the one that we work in, we see a lot of patients who've had a stroke. And so I knew that the acute rehab setting was for me. And I searched high and low looking for a placement that had acute rehab. It was very tough. There were not a lot of people hiring. I had interviewed some certain places, but I also was a little bit sick of New Jersey and the traffic and a ton of people in a very small space. And so I started branching out, and I knew I kind of liked Texas. I lived here when I was very little. Don't remember it. I think I was under a year, but I started looking and I applied to a job in San Antonio, and they called me and they said, well, this job is full, but have you ever heard of Kerrville? And I said, nope. I said, okay, well, you probably know Fredericksburg? And I said, nope, I don't. Yeah, I'm from New Jersey. But I applied here anyway. I had a phone interview, and our director at the time was like, well, how quickly can you get here for an in-person interview? She was like, can you be here in like 2 days? I was like, maybe I have to start driving now. And so, but I was there in 4 days and very quickly bought a plane ticket and I was here. But I had to adjust to Texas very quickly. So I was a brand new graduate by myself in Texas on the other side of the country. And I told the other class I spoke to that I had no idea what a tamale was. I thought it was a candy. I just learned a few months ago what that is. It's confirmed. I haven't had one yet, but I know what it is. So that's good. So I am a immigrant for sure. But this was one of those things where every sign was pointing me to come here. For some reason, it was pointing me here. And from what I've said, and Candace and Kat, and Mary will share with you too, it's not always a straight road. If it's a straight road for you, that's awesome. There's nothing wrong with that. But there are bumps, there's turns, there's lots of red lights, there's yellow lights, and sometimes you may end up on the other side of the country. You may end up in a totally different career. It's very interesting. And so just listen with your heart, like Kat said, and follow what you think is best for you, and you will get there. I promise.
Hey everybody, my name is Mary. I'll give you all a minute. Hold on. Let me know when you're ready.
Got it.
We're good? We're good? Okay. Anyone here a nursing student? Excellent. Great. Okay. Well, I'm going to talk to y'all and I'm going to try and make some things applicable to you guys too. So I'm a registered nurse. And let me talk to you a little bit about my path, about how I got here. Yes, that is me. You're welcome for this excellent picture. So the first is me on my very first day of nursing school in 2017 on the precious little baby of like 28, I don't know. And then that is me on my graduation day, almost to the day 3 years ago. I just celebrated my 3-year anniversary being a nurse. Very exciting. I have a bachelor's degree that I obtained in 2010 from a liberal arts college in Virginia in comparative religion. Now you tell me what to do with that. Anyone? No, excellent. So I graduated and I immediately got my teacher certification. I was going to be an EC through 6th grade teacher. I did not use that. Instead, I became an assistant youth programs director at the YMCA of the Rockies in Colorado. So I was in charge of their summer camp, after school programs, all that exciting stuff. And in the process, got my wilderness first aid certification. And that was just about the coolest thing I've ever done. So from that, I became a counselor at a residential youth treatment facility. This was boys, girls, young men, young women, age 12 to 21, who were gang members, sex offenders, prostitutes, anything you can think of, aggressive things, just a step down from juvie. So in that process, now having that little wilderness first aid bugs kind of sticking in the back of my head, I got certified to pass them their medication. And that just kind of blew my mind. I was like, look at all these cool medications, look at all these things, how it works in the body, the effects it has on their mind. They're, you know, all about that. That didn't last too long. My father was in not the greatest health. He had Parkinson's disease and it was diagnosed pretty late. So something that as therapists, y'all would definitely see a lot of and have to know about how that works on the entire body. So because of that diagnosis and seeing that he was kind of towards the end of his life, I became CNA certified. I was thinking already, I think I want to be a nurse after now having several different careers. So I was actually finished my CNA certification kind of to test the water, see if I wanted to pursue a path in healthcare. And I was actually able to provide end-of-life care for him in 2015. And I know end of life is very, very scary to a lot of people, especially when you're starting out your careers. But honestly, it is the best gift you could possibly give anyone. So don't be afraid of it. It's really a beautiful and touching thing that you can do for someone. Let's see, let's go through the next slide if you don't mind. A whole lot of information. So not only am I a floor nurse, I'm also a charge nurse here at Peterson. So depending on the day of the week, I'm either on the floor, very closely interacting with patients, or I'm kind of overseeing the unit for that day. As you can see, regardless of my day, I get there super early. I always recommend people get there early so you're not rushing. You can get your patient assignments and kind of look through and see what your day holds. As a floor nurse day, typically it's a whole lot of charting. You can kind of see that for yourself on that side as I break it down. Any chance you have to chart. Something that is cool about being a charge nurse is rounding with the doctor in the morning. She usually starts about 6:30. I finish getting a report about 7, and I get to round with her on all the patients, see how they're doing, see how their night's going, see if they have any issues, concerns. But it's really an excellent learning opportunity. And then some days we do a team conference meeting, and that is a really incredible opportunity where everyone comes together, physical therapy, occupational speech, the doctors, nursing, all come together, and we talk about that patient for the day from all different angles. And you can see how well and closely we will have to interact with each other. The rest of the day pretty much is spent supporting the staff that are working that day on the floor, rounding on patients. And yes, as a charge nurse, I answer call lights, I admit patients, I take patients to the bathroom. And I think that's something that's really important for everyone to remember, is that no task is ever beneath you. A lot of times people will think, oh, well, the CNA or the PCT, they take them to the bathroom, or they clean them up after they've had an accident. And there's really no better opportunity for a nurse, or I mean, even as a therapist, if the patient has adaptive equipment, or if you want to see if they have any other issues going on, there's no better opportunity than to check them when they're in the bathroom for pressure ulcers. That is huge with our population right here, especially with the geriatrics who have very frail skin. It's very easy for their skin to break down. So I take the opportunity, if I'm available, to go take them to the restroom, and it's a lot less awkward to say, hey, I'm gonna check your backside to see if you have a pressure injury, than coming in at some other time and saying, hey, let's take off your pants so I can look at your butt. Like, I'm sorry to be blunt, but it's a lot less awkward for them and for you. It's more natural that way. Does anyone, out of curiosity, know where the primary areas that pressure injuries develop are? Yes, ma'am. Your tailbone, yes. So like the coccyx and the sacrum, any other places? I know I kind of tipped you off with looking at butts, right? We look at elbows, we look at their heels. So some people may think, oh, the PCT can put on their TED hose or take their TED hose off. Well, I'm gonna take those off and look at them for myself. At the end of the day, the patient is my responsibility. Another one that people don't think of is oxygen tubing, right around the ears or on the tip of their nose where it hooks in. So really, we look at the whole patient, and we definitely appreciate when the therapist might give us a heads up on, hey, I took them to the restroom, because guaranteed all of these ladies have also taken patients to the restroom, help them in bed, help clean them up. So they're also one of our lines of defenses. Okay, so rehab nursing, I know I've kind of gone into it, and if this slide looks familiar, it's because Samantha already had that slide, unless you took it out. You left it in there? Okay, I thought you did. Acute rehab nursing is really, it's not something that I had planned on doing. I initially worked on a cardiac floor in San Antonio. That was my very first job. That was very, very scary. Rehab nursing is very unique because of the level of patient interaction that we have. We really get to know our patients. Sometimes on the floor, patient gets admitted and discharged in the same day. But with acute rehab nursing, the average length of stay is 10 to 12 days unless they've had a stroke, in which case they're there for usually about a month. You really get to know them, get to know their families, and really develop very, boy, you sneak peek in the next slide. You really get to know them and their families and develop really very special relationships with them. Every day is a challenge, and definitely lack of monotony. our director describes our floor as Med Surge Plus. So not only are we doing the typical things you would see on a Med Surge floor with occasional exceptions, we don't really see that many NG tubes or things along those lines. But yes, we're administering blood. We're managing heart failure and just really helping people out. So the reason I love the acute rehab unit is because of the family that we are. And I know that sounds so trite and so overplayed and so oversaid, but we really truly are a family. And I gave pictures to prove it. So I have pictures of us hiking at Enchanted Rock. That's us on Valentine's Day. We do not get holidays off, and there's us on New Year's Eve. We celebrate the births of each other's children. We go to each other's weddings. That's our friend Stephanie, who we went to her wedding, and she just had a baby, so she got double the love. And then the last one is a picture of me and my coworker Brian. We completed a class, a year-long class for, I just lost the total name of it. I'm trying to remember the name of it, but no, it's a course for new nurses, at least new nurses to Peterson. And so if you see anyone with the little lamp on their badge, that means that they've completed that course. And we presented a project to the board at our hospital. So definitely a really special group. I'm fairly certain I can say easily that we have the lowest turnover rate. We've all gotten very close together, and every day that I get to work with people like Kat, Sam, and Candace, and Colby is really a special day where I count my blessings for sure. I'm happy to, I know y'all aren't nursing students, but if you have any questions about nursing, I'm happy to answer those as well. Or if you know someone who's interested in nursing, LVN, RN, BSN, I'm happy to answer any questions that they might have too.
Colby, could you check out the chat box on Teams to see if there's any questions?
Oh, and you tell me how? Oh,
We still have time. There you go. Questions for everybody.
no.
Okay, sure.
What's up, Candace?
We're gonna kind of open up for questions and check this, and just a couple of things that come to mind. I don't know what, maybe, what's one, I want y'all to think of what's one thing that just strikes you in what we consistently said between PTOT, speech, and nursing. Think of one thing that stands out. Think of one thing that you think causes our passion or our love of what we do. And then one thing about what reminds you of something maybe your mom and dad or someone that you really trust and love has said to you in this career path that y'all are on, because everyone wants you to be so successful. But one quick thing that comes to mind, and maybe me speaking as an older speech pathologist, an older therapist, as a leader in the past, I'm not an official leader at Peterson, but we're all leaders of sort. And I've been trained to be a servant leader, just as our director, Elizabeth Johnson, is. She's a servant leader. So there's so much of what we do in therapy that can lead you into leadership. It can lead you into marketing. It can lead you into a program development. It can lead you into different avenues of healthcare provision. So, you know, and then different times in your life, you're given new opportunities. Would I like to develop a new program? I developed an orthopedic program at a hospital over a 4-year. How could a speech path create an orthopedic program for a hospital system for 4 years? So you're going to be given odd desires or opportunities, and then you decide, do I have the skill set? Do I want to build that skill set? Am I willing to be mentored? So this is what it leads into being. So if you're a cultural generation, your generation thinking as a millennium, your willingness to be teachable, your willingness to listen to correction, your willingness to be held accountable to what the requirements and the policies are. I'd have to be very honest with you. In my career, I really see sometimes a breakdown of why do I have to show up on time? I want to show up when I want to show up. I don't really want to do that. I think my way is better. Well, the director says, you know, this is our way and I'd like you to do it. That accountability to follow a process. Can you follow a process without someone on you one-on-one? that kind of thing. It's really hard because y'all are very quick. You look at media, you want everything really fast. I want it now. I want my house, I want all these things. But in healthcare, I would have to say, it's the slow and steady. You have your dreams. We're very high performers. I bet you every one of you guys are probably considered a high performer. Y'all are probably considered above average in your academic abilities and maybe even your discipline of learning. But it's really, really easy to lose that discipline and that focus. People ask me, what has made me a great speech path? And all these ladies will say to you, I'm process driven. I do things very much the same. I hold myself very accountable. If I make a mistake, I'm the first one to say, hey, I'm sorry. But I try not to make a mistake because it could affect my patient care. It could affect our team and affect a lot of people. And then it's also the arena of ethics that Sam alluded to in our society right now that's very fast paced. If I say it enough time, it becomes the truth. Not true in healthcare. Everything can be tracked and can be documented and can be reviewed. And to reduce error is the goal of our hospital. Basically, our hospital says our goal is no error, which is nearly impossible, but it is only possible if you're diligent. So that's one little word of encouragement I would say to you guys. When you're going to be interviewed for internships, I have a student right now interviewed 3 students. Every one of them are going to interview in a different way. You want to be really practicing how you can answer some pretty tough questions. And I'm sure that y'all's professors are working on that for y'all to get key internships and positions and accepted into college. Your interviewing style, the way you can speak, and the biggest other thing next to typing is writing. I will not hire a speech path without seeing how she can write, legible. I want to see how they can spell. Do they have grammar when they write? So these are things, no matter what you go into, are going to be very important in the decision for you to be hired. Of course, Sam, we knew she would get hired because she was so awesome. But anyway, all of those things. So what are some questions you have? What are some input that you can give our team? We're all available to answer the questions in whatever way that we can. Anybody? Yeah, we can chat after, whatever y'all want.
Well, if you guys don't want to ask this, Colby's a great resource, because she graduated from here.
Oh, yeah, if you want me to talk, I'll talk, but
She got a job as a rehab tech.
Yeah.
She also wanted to be a physical therapist, and I strong armed in occupational therapy, but she
That-
was able
sure.
to kind of see just different areas, and she got to see nursing, she gets to see the doctors, and she gets to see the entire process. So Colby is an awesome resource for you guys. We use her so much, and while we're super excited that she's becoming a CODA, we're really sad.
And she's ultimately going to become a speech therapist too.
yeah, so I graduated in 2018 from Schreiner. I have my Bachelor's of Science in Exercise Science, and I was on a pre-professional track for PT. I did college a little different. I had my son when I was in my sophomore year of college. So I took off my spring semester. I started back up in the summer, and I graduated on time with a 3.3. I wish it was better, sorry. I took a year off because I said, hey, my son's 2 years old. I want to get married because I was already engaged. I want to get married. So I took a year off. I got married. And then I was like, you know what? I took a year off, and I didn't follow or shadow anyone. I didn't do what I was supposed to do. So I started looking for jobs, and it just so happened that they had an opening at Peterson for a rehab tech, which is exactly what I wanted. I wanted to work in their therapy department. And it just so happened that their last tech had applied to OT school, and so I got her spot. I have been working there a year and a half now, and I am so thankful because I really came into it wanting to do physical therapy and was like, yeah, that's not for me. I am currently back in school. I started in January to become a CODA, which is a certified occupational therapy assistant. And I'm kind of going through what y'all are going through, trying to figure out how to deal with this COVID stuff and go to school and, maintain what is life. But I guess that's really it.
You know, the thing too is our last rehab tech was like so awesome, and everyone on the team said there's no one that can be as good as this rehab tech that went off to school. And we were mourning, we prayed, and so anyway, COVID comes on.
And I'm 5 times better.
So awesome, it's so wonderful. And then when she had our first annual review, we basically said you are better than me. So we sure appreciate everything Colby does.
Yeah, so I work with, I didn't really say what I do. I work with everyone. I work with physical therapy. I work with occupational therapy. I work with speech therapy. I also work with nursing. I help PCTs. I help nurses if they need it. I go in the mornings when I get to work. I pretty much do, I guess what you would say, paperwork, and then I go write schedules on the boards, and that is pretty much the most important time to me because I get to go into the patient's rooms and see how they're feeling. Did they have a good night? Are they getting up for breakfast? Is there family in there? What's the family worrying about? What's the patient worrying about? Are they depressed? I don't seem to them like a therapist or like a nurse. So they tend to confide in me more, which is nice because I want them to confide in me, you know? So it helps in that sense that they joke that I know everything, but I do know everything. I get the behind the scenes that they don't get behind the scenes. So I really do love my job, but I can't wait to be on the other side of that too, as a coda. But yeah, if y'all ever do have any questions, Dr. McAlexander does have she's gonna cringe that I called her that. She does have my information, and I would definitely be happy for her to give it to anyone, so.
Absolutely.
So hey, I'm Dr. Community, for those of you who are visitors here. I'm sorry that I'm seeing students this whole time, so I got in here late to you. But my question for you is I'm talking particularly to freshmen and to others who are interested in exploring some of these fields. How is it working for taking people into the hospital in shadow right now in the COVID world? And what changes do you see coming up? And do you think that might be approachable?
So I had a student recently ask about doing shadowing, and what I got from our director was that we're going to open up to visitors first and see how that goes for a few weeks, and if that goes all right, then we're going to start allowing shadowing students. So our visitations are a few weeks now.
And we have auxiliary started this week.
So hopefully, fingers and toes crossed.
So the news that has come out while y'all have been in here is that we are still at 0 cases at Schreiner University.
Hey. Yes, and we have taken students for our inpatient setting and also our outpatient setting. Nursing students from Schreiner actually already do go to Peterson currently and have been, but I know that was kind of a thing. When I was a senior, I had no idea that I could go to the hospital. I didn't know that. They told me, oh, you want PT? Go to NIMKE's or go to sports medicine, which are both physical therapy places here, but I didn't know the hospital was an option. And it definitely is. We would, I mean, I hear it from the therapists and stuff like that a lot because I have worked inpatient and outpatient. They love the chance to teach anyone.
I think we're very close to opening it up. You know, my suggestion for whatever leadership is to contact Elizabeth Johnson, our director of rehab. She's in close communication with all the leadership and opening up stuff. Our hospital has been very active in supporting students, even through COVID. All of us have students, but I know the student is one thing different than the shadowing. So I think we're close. I think we're really close. We're just trying to work all the details out.
And do you know we're starting a communication disorders degree?
Oh my
wow.
God. Just tell you the dream. It's common. Can you believe it? So, you know, I taught at University of Texas and Texas State, and Kobe so graciously with your help organized this, and I found out I was going to be allowed to present. I said to Kobe, you know, right, Kobe?
Yes, yes, you did.
I would like to return to 3 or 4 years. Maybe.
It just keeps getting bigger.
Instructor. And so I would be so honored to do that. And I think it's it's God opens up golden opportunities. This is a golden moment, not just for our rehab team and Colton, but the opportunity to do that. I would love to help with that.
I just got you.
So Dr. Kamuzi is our developer of health professions
nice.
here. So
And
yes,
how do you say your last name?
Brunswick Jacuzzi. Jacuzzi.
there you go. Well, that is our time here. We appreciate you so much, Peterson Health. Thank you. Thank you for being here. And I'm sure our team will stay here after. Dylan has gifts for all of you as well. We appreciate your time and effort.
Made them myself.
Do you want me to share? Yes, please. Thank you. Absolutely. If you'd like to stay after and talk, is that
Yeah,
okay?
that's okay.
One-on-one
Yes, please.
questions, you're welcome.